Hello, everyone. Ladies and gentlemen, I'm Dr. Chi-Cheng Huang from Taipei Veterans General Hospital. Today, my topic is about the concordance of target sequencing from circulation tumor DNA and the paired tumor tissue, especially for early breast cancer. This is my disclosure. As we know, circulation tumor DNA or ctDNA is a free form of DNA bound to proteins in plasma that originate from tumor. And tumor-derived DNA may only be a small fraction of the total cell-free DNA in the space of plasma. With the advance of next-generation sequencing, NGS, this technique has developed the detection of ctDNA in clinical settings. With the potentialities of selecting therapeutic target in metastatic settings. Because during the metastatic settings, the disease burden is high and the chance is also higher to detect a variant from this liquid-based biopsies. So we can use the information detected from the circulation tumor DNA to interrogate, including the tumor clone evolutions and monitor the therapeutic response, as well as to find a novel therapeutic target during the disease evolution. So the purpose of our studies, including we want to evaluate the concordance of target sequencing result between paired circulation tumor DNA and the tumor samples from the same subject from a cohort of early breast cancer cases. All these cases is scheduled for curative surgery and with or without adjuvant setting. That means all these cases are from early stage and is planned for curative intention, and this is not the metastatic setting. So this is a special point of our study. Second, we hypothesize that the pre-operative circulation tumor DNA testing could serve as a non-invasive surrogate of variant meant to be detected after definite surgery if high concordance is observed. So I need to highlight here, this is earlier stage of breast cancers. So usually when you check the literatures, most of trials is especially performed for the metastatic setting. So this is one merit of our study. And the primary outcomes were the actionable mutation determined by genetic profiling of Taiwanese breast cancer using NGS comprehensive assays from both the liquid biopsy and the tissue origin samples. Okay, this is our study population. And the whole population and the protocol has been published under the clinical trial named VGH-TAYLOR. And this study is regarding the comprehensive precision medicine research regarding the heterogeneity of Taiwanese breast cancer cases. And we have three group patients. Group 1 is planned to receive surgery first and followed by adjuvant therapy, including endocrine, chemo, target therapy, if any. And group 2 is planned to receive neoadjuvant therapy first as the first-line treatment and followed by definite surgery. And group 3 is including those diagnosed with de novo stage 4 disease or they have breast cancer recurred after their treatment at least 3 years. So in these current studies, we only interrogate patients from group 1 and group 2 because we want to evaluate the value of the ctDNAs for patients with early stage breast cancers opposed to metastatic settings in most clinical trials. The measure of the NGS target sequencing is performed, and you can see that from the same subject, both the tumor samples and the plasma samples were collected. We need to highlight that for plasma samples, all these blood samples were withdrawn before the treatment began. So that means the timing of the tumor samples may during the surgery, and the plasma samples may be a little earlier, maybe a days or maybe 1 to 2 weeks before the definite surgeries. And after the two kinds of sequencing platforms with library preparation, NGS was performed and the data was analyzed. And we can find that for the SNVs, indels, and copy numbers, and we connect both of the results of the same subject, and we try to evaluate the concordance of the genetic variant detect from the tumor tissue and the pair blood liquid biopsy. Firstly, we see that in this trial, about 3 years ago, we have an initial presentation, and during the times, we report the result with the tumor tissues. As you can see that there are around 600 tumor samples, among them 214 patients will report at least one actionable mutation. That means the actionable mutation rate from tissue only and the tumor only sequencing is around 39%. Next, among these 640 patients, there are 246 cases assay for both the liquid biopsy and the tumor tissues. So the primary study subject of current report. And we see that for the liquid biopsy ctDNA assay, there are 73 patients, or roughly 30% of patients with at least one exome mutations. On the other hand, from the tissue, the about 200 patients report at least one variant from their tissue tumor-only sequencing. So you can see there's a big difference between the detection rate from the liquid biopsy and the tumor tissue. The detection of liquid biopsy around 30%, and from the tumor tissue is around 80%. So it is not strange to find this finding because this is from early settings of breast cancers. And we can see that the most prevalent tumor genes from the ctDNA assays with at least one variant. Don't forget that only 30% were detected with the tumor detect with at least one mutation from liquid biopsy. And the most prevalent one was the TP53, around 90% of all the assays with at least one mutation, followed by PIK3CA, KRAS, ERB3, and SF3B1. So it is interesting to see that the order of the most prevalent genes and the magnitude of the detectability between the tumor and the liquid biopsy is an enormous change. So that hints that in the early settings, the tumor-only sequencing from the tissue may be a better method to detect than the liquid counterpart. On the other hand, we want to investigate the concordance. So among them, around 1/4 or 67 patients were tested positive for both the liquid and tissue assay. So among these patients, the concordance is exactly the same. And if you take a detailed look at the liquid biopsy, you can see that they have abnormal detect additional cases of variant, and we will see later in the following slide. So this is the mutation maps of the liquid biopsy. As I mentioned previously, 248 patients have both platforms, and this slide shows that only 30 of these 250 patients have at least one action mutations from the liquid biopsy. One reason for this discrepancy comes from that the liquid biopsy panel interrogate only 10 genes, while the target sequencing panel for the tumor interrogate 161 genes. So there's a difference in the layout of the target sequencing. As you can see from this onco print, you see that TP53 at the bottom of this paragraph. You can see that it has the most prevalent rate. So as we know that TP53 is one of the major driver mutations during tumorigenesis. So it is not a surprise that we find result. However, if you see that other genes, just like the PIK3CA mutation, ESR1, and the ERB2, ERB3, EGFR, AKT1, all these are actionable currently for breast cancer because there are somewhat at least one kind of targeted therapeutic agent for these mutations. Okay, and this slide shows the SAM order of the sample at the x-axis, and we can see that we narrow down the full panel to the common genes interrogated by these two platforms. And from this 246 early breast cancers with the tissue, and the hit rate that which means that at least one actionable mutation were found, was 80% for the tissue. And also the TP53 was the most prevalent with 64% of the patient report TP53 mutations, and followed by the PIK3CA and the ERB2, and the others are less than 10%, include the AKT1 and the ESR1 and the KRAS and the SF3B1. So at these tabulations, we highlight the most common sex genes common to the both platforms, which means that these genes were interrogated by both platforms, including liquid biopsy and tissue. And we can give a detail regarding how this variant were detected, including if this variant detected by the tissue only, or by the ctDNA only, or both detectable or both not detectable. So the first three columns means that at least one platform identify this variant. So as you see here, around 68% of SA samples report at least one platform reporting abnormal in TP53 genes, and the rate was about 40% for PIK3CA, and 53% for KRAS, 17% for ERB2, and 45% for AKT1. So among these patients, both detectable seems less than the tumor tissue. So it is quite reasonable because we mentioned previously the whole study population come from the early stage patient only, and they are treated for intention. So at that time, the disease burden is low. So it's quite intuitive to say that okay, we may not identify a patient from the liquid biopsy phase, because most tumor is localized and they don't go beyond the tumor without regional lymph node metastasis. So it is quite straightforward to see that the detection rate of ctDNA is low. However, on the other hand, you can see there's still one case of AKT1 mutation, 4 cases of KRAS mutation, and the 50 case of the PIK3CA mutation, and around 1/3, 1/4 of the TP53 mutation were only detectable from the liquid biopsy, not from the tissue, especially the TP53. So it is very interesting to have a detailed insight of this patient. While this patient, they don't have the mutation detected from tumor, however, they have liquid biopsy proof mutation. So is this patient these cases have a poor prognosis because they have an early phase of liquid biopsy detectable mutation than the tumor. It deserves further evaluation. So I think this is a very interesting point for this study. Now we go to the destruction section. From our presentations, we see that the most prevalent mutation genes for both platforms were the TP53, accounting for around 70% of all the cold variant, and PIK3CA mutation around half of all the SA samples. Both were well-known cancer driver genes. And the PIK3CA mutation or amplifications were by far the most common ASCAD alterations identified from Taiwan breast cancers. That means 37% of all alterations and 35.8% for mutations. And for the mutations, the PIK3CA mutation is belong to the ASCAD Taiwan A mutations, especially thanks to the appellate, which is the PS3K inhibitors for patients with the hotspot mutation of these genes. Our study shows that tumor should be the preferred source for target sequencing because you can see that the detection rates of the tumor source for target sequencing is much higher than the liquid biopsy, especially for early stage of cancers. However, there's still a chance of additional 4% variant not detectable by the tumor only sequencing, but was identified from the liquid biopsy of the circulation tumor DNA. Among the 81 patients with ERB2 amplification, which was the SK Taiwan A variant, we see that 15 or 18.8% were clinically HER2 negative, indicating that target sequencing may identify more HER2 positive breast cancers than traditional immunohistochemistry and in situ hybridization assay. This is very important because currently we define HER2 overexpression is based on the ISH or the IHC method. However, using NGS, you can identify additional around 1/5 of patients which are clinically HER2 normal. However, they are meant to be HER2 overexpression using the NGS with the ERB2 gene amplification. Here we show the mutation maps of the most prevalent genes. The upper is the TP53 and the lower is the PIK3CA mutation. As a cancer driver mutation genes, you can see that TP53 has a lot of mutations. Actually, if you hop over the clean bar, you can see that there are so many annotations for TP53 and still remains some US for us to identify in the future. However, if you see the bottom panel of the PIK3CA mutation, you see that the mutation of PIK3CA hotspot is narrowed down to two places. One is the most left side, including H1047 mutations, and the middle part, including the 542 and 545 mutation. Actually, these two hotspots corresponding to the 11 hotspot of the SOLAR-1 clinical trials. So for the approval of the PI3K inhibitors, you need to have exactly the same PIK3CA mutation of these 11 hotspots. Here is our conclusions. The aim of the study was fulfilled to identify the genes generated from the NGS with target panels to understand the genetic profiling for Taiwanese breast cancer cases with the liquid biopsy and with the tumor-only sequencings. And the concordance of the covariant between these two platforms was only moderately. And don't forget, this is an early breast cancer cohort, which means that the disease burden is low, and so it's not quite wild to see the concordance is only moderately. So the assay could identify important genes and target mutations associated with cancer monitoring and detect relevant indels, copy number variation, gene fusions, and we see that the actionability based on the SK classification, we see that the value of perform next generation sequencing even for the early breast disease. However, there are still 4% of patient, the cases, breast cancer patient cases, they don't have the variant from their tumor. However, the variant could be detected from the liquid biopsy as the form of the circulation tumor DNA. So it is very interesting in the future to understand what is the meaning of this variant, not detectable from the tumor, but detectable from the plasma. It is only just by chance, or it indicates to a poor prognosis and hint to an earlier intervention, such as using a more potent target therapy at the earlier line of the treatment for this patient, deserve further evaluations. And the most common prevalent mutation gene, including the TP53, which is a cancer driver gene, but actually is currently not targetable, and PIK3 mutation, currently with at least one FDA-approved alpelisib after value of the CDK4/6 inhibitors for metastatic breast cancers. We believe that the ongoing trial will shed light on the pathogenicity, molecular heterogeneity, and treatment decision for Taiwanese breast cancers. And more results are anticipated with more patients enrolled and longer follow-up available. Now is the last slide of my presentation. We would like to express our acknowledgement because the study is sponsored by the Yongli Health Foundation and the National Science and Technology Council of the Taiwan government. And the whole study teams also would like to thank Minisali Cancer Foundation for their help. And we also express our great thanks for all the breast cancer cases participating in this study. Thank you very much.